Uh, okay, sir, it's live. Yeah, just a minute. Good evening, friends, and we are back here again with our wonderful program, and the we started with the talk show, which is an ultimate talk show. We started from Professor uh, Joseph Khan, and we had then Dr. Attila, Professor Z Major. Then we had Professor Daniel Cardropoli, and then we had the godfather of GBR techniques, Professor Daniel Boozer, and then we got a chance to have Attila Bodrogi, and then we had the dynamic duo, Dr. Snezjana Paul and Dr. Howie Gluckman. It was a wonderful session. And then we got a chance to have Professor Joseph Shukru. It was amazing. And then, so it went on like that with a lot many. We had Professor Dr. Mahesh Verma sir from India, and it was wonderful to have him here with us. And then it was Professor Dr. Scott Gans, and then the trio. It was Miltiadis, Dr. Miltiadis Mistias from Greece, along with Dr. Scott Gans as a moderator, and Dr. Isaac DeVille. So the trio, they just rocked the show. And today I have one of the most amazing periodontists from Brazil, Dr. Ricardo Kern. Welcome, Dr. Ricardo, to our talk show, and namaste. And along with Dr. Ricardo, we have the women power with us. And I believe Dr. Ricardo will be surrounded by beautiful women from India and Nepal. Um, Let me tell you, Dr. Ashvini Padhye from Pune, India. She's you are from Pune or Mumbai? Mumbai. I'm so sorry. You can unmute yourself, Dr. Ashwini. Please unmute everybody. Everybody unmute. Unmute yourself. Can you unmute yourself?
Yes.
Yeah.
Yeah.
Yes.
So
I'm so sorry.
much.
Dr. Ashwini Padhe from Mumbai, and uh, she is one of the best periodontists from India, and I have heard her uh, amazing knowledge and amazing lectures, uh, and wonderful work. Why? I believe that uh, having a good knowledge of the subject and then bringing into your day-to-day practice, they are two different things. And when you get this combination together, then it becomes amazing. So, welcome, Dr. Ashwini. Thank you so much for being with us and accepting our invitation. Then we have another periodontist from Nepal, Dr. Rita Singh. Thank you so much for being with us, Dr. Rita. Uh, she has done her studies from India, and she has been speaking all around the world. And I believe that she's into the divas dentistry, the group. She's one of the divas. And now I come to my third moderator. She's a very good friend of mine, and we were together in 1997 in AIMS, All India Institute of Medical Sciences, New Delhi. Dr. Radhika Sahni.
Evening,
She,
everyone.
yeah, welcome, Radhika. Thank you so much for accepting our invitation. Dr. Radhika is a prosthodontist. She has done her uh, uh, prosto PG from a very renowned institution in Uttar Pradesh, that is King George Dental University right now. So KGDC,
Mhm.
and yeah,
Calling.
and she has worked along with a very famous personality also for a few days. She was uh, association with Dr. Uh, can you tell the name?
Dr. Anand Kohli.
Anil Kohli. Dr. Anil Kohli, sir. She has worked with him also. And now I will introduce my dynamic team from Sahaj Dental Academy, Dr. Vaibhav Gupta. Good evening, everyone. Yeah, he is our IT guy also, because all the hosting and everything is done by him. And then Dr. Chakshvesh Agrahari. His name is little tongue twister. He works in Dr. Vaibhav works in Allahabad, and Dr. Chakshvesh he works in Kanpur, and he has a branch of Sahaj Dental Academy, and both of them have done their PG diploma in implant dentistry from UCAM, University of Murcia, Spain. So I'm really proud of them. Thank you so much for being as a team here. And without delaying anything, I would like to ask Dr. Ricardo Kern to start his presentation and share us the beautiful cases he has, and the idea behind bringing him in here to all of you was the only thing that in India the perio has to be very we have to push it, and those who are uh, I believe, firmly believe, I have a firm belief into this, that if you are doing implants, please learn, attend some workshop, and learn the perioplastic surgeries. Because if you do not know the soft tissue manipulation and augmentation and regeneration, placing implant is of no use. Perio is a very important perioplastic surgery, and especially when we are dealing with implant, the peri-implant tissue development is very important. So today, Dr. Ricardo Kern is going to talk about the balance between the gray and the pink aesthetics. So over to Dr. Ricardo Kern, and you can start sharing, Dr. Ricardo. Thank you so much, and welcome to the show.
Okay, thank you so much for this opportunity. It's a huge pleasure to have a chance to talk a little bit about my work and about the subject that I'm really passionate about, soft tissue. And I'm a periodontist, and I practice implants since I start my career. So now close to 20 years. And we, on these, all those years, we learn the importance of the soft tissue management for what I'm going to present for you today. Uh, I think most of the dentists that work with surgery, that work with implants, and not just in Brazil, but all around the world, we face the same steps on the learning process. When I start to do implants, my concern was, okay, let's open this flap, make a hole in the bone, fix a screw, and let's expect that this screw is attached to the bone. They stay there. And let's expect in the next week, when I see the patient's back, that the screw is still there. That was my concern, to learn the system, to learn how to drill, to learn how to screw the implant in place. And maybe if I was lucky, 3 4 months to have the implant ready, osteointegrated, for me to have a crown on the top of that. This is our first step. I think everybody and all around the world is the same process. And after you learn this step, you start another challenge that is to allow for some patients that have loss of bone to bone build this area, to allow these patients to receive the implant treatment also. So we start to learn how to bone grafting. And all around the world, you see good books, good publications, good papers for many, many years of different techniques that work and can bring for these patients this kind of opportunity. Okay, and you continues to treat our patients, we continue to develop our skills on this field, and we start to look at one thing now. How can I deliver a better relationship between what I'm building, my bone, my implant, and the crown? So the relationship between the prosthetic position and the support position. So we start to build a bone, not just to allow the patients to receive the implant in place, but to have a better position of the implant related to the prosthetic outcome for this patient. And this is the third step. But even manage all these three steps, for many, many cases, we are not allowed to deliver for the patients a crown that seems like a natural tooth. And for that, we need to learn how to manage the soft tissue also. So in all those steps, the soft tissue really came to bring to me this kind of refinement, to have a balance between the white part that I'm giving for the patient, the crown, the ceramic, and the pink part. So we need to understand that, we need to manage that, and the soft tissue management, when we are discussing at this degree of specification, we need not just learn how to graft, we need also learn how to condition and to modify this shape of this tissue. We need to plan how a perfect contour of the soft tissue must be made to achieve this kind of result. So it involves many steps also. And my goal today is to bring to you all this philosophy involving in this process, how to plan, how to graft, how to condition, in order to bring this importance. And we're not so far still discussing the importance of the soft tissue for the maintenance of the health around the implant, for the maintenance of the bone around the implant. And we know nowadays the extremely importance of a good and healthy soft tissue to protect and to make that everything that we are building to endure as far as long as possible, because really the soft tissue is not just for the beauty, but is to protect and to seal everything you are building on the peri-implant area. So first thing that we must understand that really is how to plan our surgery. Many people that work just with surgery sometimes start to do, okay, let's do bone grafting, let's do some implants, let's do some soft tissue grafting. And at the end of the procedure, the contour obtained is not exactly a perfect contour for a crown without pink ceramic. We need to understand how far we need to build that and the place that we need to build, because you can graft, but sometimes if your goal is not attainable, you cannot achieve exactly a perfect contour, you can really at the beginning opt really for a prosthesis with pink ceramic, and you're going to avoid for the patients to receive many unnecessary surgeries for this kind of treatment. For crown lengthenings, for aesthetic treatment, we need to understand the design of the soft tissue. For conditioning, when you graft the soft tissue, you need to understand which is the design, the proper design that this soft tissue must to be shaped. So treatment planning is fundamental, even if you work just with the surgical part of the treatment, okay? So we need to understand, and we're going to bring this first step on our discussion. The surgical portfolio, usually we have many different techniques for soft tissue graft. What I'm going to bring to you is not to talk about a specific technique, but we're going to talk about all the anatomy and physiology involving in how to manage the soft tissue. So if you understand that, you're going to understand better different techniques. And you're going to see that even if we are talking about different techniques, the basic principle of how this tissue works, how this tissue heals, and how to manage this tissue, there is a lot of in common. So I think it's more important for us to understand that than really memorize different techniques, because my patients, all the patients that came in, everyone has a different kind of defect. If I try to identify, okay, now I need to apply this technique or that technique on this technique, and you're going to be crazy and probably not going to fix the proper technique for the proper defect. If you understand how the tissue works, probably you can understand better and identify which technique is going to be appropriate for that kind of case, okay? So in this short time, my goal is really try to bring some information about how to manage the flap and how to treat the tissue for this kind of approach, okay? And for the last but not the least, it's about the conditioning. And really, I think it's the hardest part of all this sequence, because we need to learn how to graft. And is a little bit different when I graft from root covering than I graft for site over implant. If I'm intending to build a lot of tissue, to build a papilla and so on, because the size of the graft, of the soft tissue graft, sometimes is way larger. For root covering, we work with graft from 1.5, not more than 2 millimeters in thickness. In the aesthetic zone, when I need to build up a papilla in case like this one, sometimes we bring graft with 4, 5, 6 millimeters of connective tissue. And the way we treat this tissue must really be very careful in order to maintain and to have as my result these 5 millimeters preserved on this area. And for me to really have a tissue with this kind of shaping, I need to let this tissue to heal. And just after the tissue get mature, that I'm going to modify this shaping, doing the conditioning of the soft tissue or the area that I have grafted. And I need to have a technique for do that, because if you do not have a technique to do the conditioning, it's a kind of crazy process to achieve. I think everybody one time in life tried to do a conditioning of a pontic, of a lateral incisors, as an example, straight in the patient's mouth. So we add some composite, we add some acrylic on the cervical margin of the pontic and pressure against the soft tissue, wait 10, 15 minutes, okay, it's not blenched anymore, I can add something more, and pressure again, the patient starts to complain, so you give anesthesia. When you see you pressure too much, so let's take a little bit of the composite and let's see again, okay, the zenith is not in good position, it's for the another side, and take a lot of time to do that, and it's kind of crazy. Imagine a case that you need to do for 3 teeth, 6 teeth, a full arch. So how can we control precisely this modification without have a lot of stress? So we have exactly the proper tools to do this kind of conditioning with very low stress appointments with the patients to make possible this kind of treatment, okay? So we're going to pass all these 3 stages during our discussion. we're going to stop in one of the stages between one another to open to questions. So you can send your questions on the Q&A, and the people that are following on Facebook, I think someone is going to screen this question, and you have time to discuss that PR everything, okay? So let's bring the soft tissue contour. So I'm going to need and to understand the importance of digital planning, or at least a planning when I can bring together the white part of the treatment and the pink part of the treatment for my patient. Just to bring the importance of this kind of understanding, I'm going to show you 3 very fast cases for us to understand the importance of the treatment. When I start a treatment for the patient, the first thing I'm do on my picture, my close-up picture, is to bring information from the face of the patient, because we are treating a smile that belongs to a face, and I need to understand how that relationship works, because I want to deliver for the patient a smile that has some kinds of harmony with the whole face of the patient, okay? So first thing here, when you see a picture like this one, a close-up picture, and these patients came to my office complain about the gingival display, the gum smile, and asked me, Ricardo, can you do something for this gingival smile? When I just looked at this picture, the close-up picture, just at the smile of the patient, the first thought in my mind, okay, I can do some crown lengthening. We're going to check how much I can move the cervical margin of the soft tissue up according to the cemento-enamel junction. But probably the design that I'm going to offer the patient, just looking to this picture, is going to have a balance between the right and left side. The same amount of soft tissue I'm going to take in one side is going to be the same amount of the soft tissue to the opposite side, okay? Because I'm just looking for this picture here. Maybe some composites on the canine, the lateral incisors, small modifications, but with symmetry. This was supposed to be my treatment for this patient, okay? But one thing, when I bring the information of the face of the patient to this treatment, let's see what happened. When I make the alignment of this close-up picture with the face, with the eye of the patient, what happened on the alignment of this maxilla? I see now clear that this maxilla and a little bit of the lips of the patient has some tilting. I have one side much lower and another side much higher than I supposed to identify just looking on a close-up picture. And now I have a big difference. Let's imagine that you are still going to offer for this patient crown lengthening and some composite, but what not here in this step to position a little different this treatment in order to offer for the patient a more related and more harmonic result to the face of the patient. So my crown lengthening now is going to move a little bit from one side and my composites to opposite side. So the result of my treatment with this small modification is going to have a better harmony with the face of the patient. So we bring this alignment of the face to the picture that I am going to start to design, okay? So let's bring another thing. Okay, Ricardo, we understand that we need to align a close-up picture with the face of the patient. And which is the next step? Okay, when I build up the setup of the new teeth of the patient, I need to do this alignment, of course, related to the lips of the patient also, okay? So we try to have the incisal edge, the incisal margin of the upper teeth with a kind of relationship with the lower lip of the patient, okay? When I see a picture like this one, this patient will refer to me for one reason: to cover the root exposed on the lateral canine and the premolar both sides. As a periodontist, if I just see these crowns, okay, if I remove this old restoration, clean the roots again, yes, of course, I can cover this root. I can bring this soft tissue currently in order to have now the proper proportion of this crown, right? Because it's a too long crown. If I do a crown, a veneer or something like that, is going to be a long crown. So I need to bring the soft tissue down. But let's understand one thing. If I need to have the incisional alignment of the patient with a kind of relationship with the lower lip of the patient, I clearly can see here that this premolar has some extrusion, so I don't have the lower premolar, so the uppers just went down, and the new alignment of this whole set of the teeth here is going to move up. If I'm going to do new crowns and the incisional edge is going to move up, of course, the gingival margin, the gingival contour that was once showing some root exposition, the proportion now is perfect for me to deliver this new crown without do any grafting, any surgical approach for these patients, because I understand that the incisal edge must have some relationship with the lower lip of the patients when possible. Of course, when I place the implant in the lower, the new crown is going to follow exactly this kind of curvature in order for us to deliver for the patient, not just a smile related to the face, but a smile related to the lips of the patient. Okay, good. Now we need to understand that what we are building, we need to have some proportion. I cannot have for the patient a very long central incisor, very short central incisor, a square one. I have some proportion of the tooth, okay? So this treatment, the patients came to the office complain about gum smile and the shape of the central incisor. You see a central incisor that is a square central incisor. In my view, as a periodontist, okay, let's use the shoe rule that give me the proportion and cut this gingiva and solve this problem. But let's see something here, okay? If I just going to deliver this new shape for the central incisors, just thinking in modify the soft tissue, I'm losing some information here. This is the example of the shoe rule. This rule, this gauge is going to give me the proportion between the width and the length for the central incisors. And we know this, this proportion for aesthetical proposition is close to 80%, okay? It means that I have 80% in length for in width of the total length of these central incisors. If I cut the gingiva exactly close to the black marks on the apical margin, I'm going to deliver this patient more proportional central incisors. But I cannot just think the proportion itself. Where am I going to deliver this shape for the patient? When I need to start these central incisors. So I align the picture of the patients with the face. I understand that I need to have some relationship with the lower lip, but where do we start this curvature? We start this curvature from the central incisors incisal edge. This is a key point. So instead of cutting the gingiva in this proportion, let's bring some more information. You see here that I have a completely straight alignment from the second premolar to the central incisor. Something is missing here. I don't have a curvature. The canine, the tip of the canine is completely wear off. I don't have even the guidance for lateral movements. So the central incisors are where the incisal edges wear off. I need to rebuild that. Remember, I need to achieve some relationship with the lower lip. So instead of just move soft tissue and bring all the white part of this new smile up, I need to think that I need to bring a little bit down also. I need to start this curvature, establish the proper position of the central incisors. And for that position of the central incisor edge, that I'm going to move the smile curvature related with the lower lip of the patient. And from this point that I'm going to build up and set one by one the proper shape and the proper relationship between width and length for each of these teeth align each other, okay? So in this case here, we identify that we need to bring a little bit down the incisor edge. There is many ways for us to establish the position of the incisor margin. We're going to talk a little later about that, but this is the starting point for the new smile curvature. I just work with the surgery, but I need to understand that if I had in the beginning cut the gingiva with the using the rule of the proportion and send this patient for someone to do the veneers, and the guys go, okay, now I have, if I bring the incisor edge down, I'm going to have a much longer central incisor. So I cannot do that, or I'm going to send back to Ricardo for Ricardo graft this root. So we need to identify that for many kind of treatment. Crown lengthenings, soft tissue grafting, root covering is important, the treatment plan that we understand to apply that, okay? So from this point one, I can design all the other teeth and have the measurements of everything I'm going to do. I'm going to talk a little bit that in the next case that I'm going to present, how to make this measuring for a precise treatment plan from the beginning to the end. Everybody can do the same treatment plan. I can do the surgery exactly following this measuring. The guy that is going to do the wax up and the veneer or the crown can know exactly and measure exactly this modification for deliver the patient exactly what we are talking about. Okay, so these three fast case was just for us to be aware of the importance of my treatment plan to deliver the best for the patient. Okay, I think it's a powerful tool for team communication. When you do a treatment plan this way, you can send your case for the periodontist. You're going to receive back exactly the modification expect. You can send this case for the guy that is the restorative guy of your team. You can send this picture and the cast for the technician, so the technician can do exactly the wax up the way you are designing. So we're going to improve a lot the precision of the treatment, and you're going to save a lot of time during this process, okay? So we're going to bring now a larger clinical case, and we're going to discuss each of these steps. For a treatment plan that we need to design a new smile, we need some pattern, some protocol of the photograph that we are working on. Usually we have 3 photographed or 3 pictures to design a treatment plan. And you're going to understand why one of these pictures is here for. So the 3 pictures, first that I have is with the lips at rest for the patient, okay? Second one is smile, and the third one is a smile, but with the lower arch a little open, not touching the incisal edge from the upper and the lower. What is the reason for each of this picture? And many people start to, okay, I'm not going to do digital planning. I don't like computers. I'm not going to understand how to design which of the lines and so on. And we need to understand that the digital design it's the same step by step that we do when you are working in a wax ring for a full denture. When you are producing a full denture for your patient, you make the first impression and you receive from the lab the wax ring. And we're going to make some marks on the wax ring. What is this mark? To give the information for the technician to set up the alignment of the crowns, the stock crowns here. So what you do? You are with the wax ring in the patient's mouth. What you do? A middle line of the patient. And you more or less balance both sides of the wax ring with the face of the patient. What you are doing? You are aligning the wax ring with the face of the patient. This is exactly what I'm talking in the first fast case I told you. What you do next? We check the incisional edges. So with the lips at rest, we make a small cut in the wax ring to tell to the technician where to position the incisional edge of the central incisors. Oh, great. I get that. And from that point, we start to cut the wax ring to give a curvature for this wax ring. This is another incisional edge is going to stay. So we are working in the smile curvature and the mouth corridor of this patient. So this first picture that I take for the patient with the lip at rest is to give me the information, is one of the ways where do I start this new smile, the incisional edge of the central incisors. The another two pictures is to have the relationship for the other incisional edge and the mouth corridor. We work in this third picture with the lower arch apart from the upper because it's easier for me to make the visualization of the incisional contour because you see the shadow of the tongue or the mouth of the patient and you don't have the interposition of the tooth, so you see better the incisional contour that you are working and design on that. On this picture here, you have this picture balanced horizontally and you're going to enlarge these pictures to work just on the close-up picture. What I need to be careful to have this picture. What is the alignment that I need for this picture? So when you are working to produce a full denture for your patient on the wax ring, when you cut the middle line of the patients, you need to look for your patients from the front. You're not doing a middle line looking for the patients from the side. Same thing is when you are taking this picture. You cannot take and work in a picture that the face of the patient is this way. One side showing much more than the another one. If I smile here, you're going to see much more the one side of the alignment of the teeth than the another one. So I cannot work in a picture that I don't have right and left alignment. I need to have the face of the patient really center this way, okay? Another thing, I cannot design a smile curvature of the patient if I take a picture with the face of the patient look up. So I do not see the relationship of the lower lip with the incisional edge. I need that the face of the patient stay in the same level, maybe 10, 15 degrees down. So when I smile, I'm going to identify this relationship and I'm going to have an easier way to identify mouth corridor and the relationship of the lower lip of the patient. Simple like that, right hand side, balancing the center and 10 degrees down, okay? So you can work on this picture here. In Brazil, most of the dentists do not have the photographic equipment to work on. So when we ask a CBCT, when we ask a X-ray or something like that, the lab provide us with this picture. We just need to have a good conversation with the guys of the lab to send you these pictures for you to work. And we do this design in very, very simple software on PowerPoint or in Keynote. Most of the time are free software. You have that in your computer and you can work and produce everything I'm showing to you on this free software. And everything I'm going to show here is producing my Keynote, not a specific, not a paid software. So it's nice for us to understand that, okay? So the alignment of this picture now that I enlarge, I already have the middle line of the patient, and I know exactly that this close-up picture have some relationship with a face completely horizontally aligned, not tilted from one side, not tilted to another side, okay? And there is another great benefit on the design. How can I explain that? When I start to do dentistry, the first anatomy classes that we have to identify the teeth, I could not tell if I was in my hand with a premolar or a molar, okay? Took me 2 minutes to know that the smaller one was premolar, the largest molar. But after some times, I could not tell if a molar was up, lower, right, or left. I need to study more. Or more 2 hours, I could tell exactly if our upper molar, lower, right, or left. Okay, I can identify that after 2 hours and something, but I cannot draw. I cannot reproduce. I cannot have a wax and do exactly the anatomy I need to do that. And that took me weeks to try to do something similar to that molar. And took much more time to start in my office to help my patients and to have a feeling on composite and do the sculpture of a molar. So that take a lot of training on that. Digital planning is the same. First time you are looking to the smile and you're not identifying even the problems that you can fix. So when you start to do by yourself the treatment plan, work on the picture, step by step, you work your mind, you develop your skills to identify the problems. And after some time, not identify how to change the design to have a better outcome. And you're going to work in many cases until you get at some point that you just look on the picture and know many points that you can produce and modify on that smile to get a better smile for the patient on the picture or on the smile of the patient live on your chair. So I think it's a tool of self-development that we need to learn how to work, okay? So let's come back for our case. We are going to work on this picture. From what I need to design here, what is the reference line for me to set up the position of the crowns? Okay, Ricardo, you told to set first the position of the central incisors, and exactly where do we start to design the smile curvature? You see that on the posterior area, you have a nice relationship with the lower lip, but all the incisor edges are shorter. You have a straight line from canine to canine, okay? And to have even the front guidance of the patient, we need to increase a little bit the incisor edge of the central incisors. We check the lip at rest of the patients to see if I can increase a little more the incisor edge. You can check for the phonetics of the patient also to see the relationship of the incisor edge with the lower lip. There are many ways to set the position of the central incisors edge, okay? So we set this position, and now what I'm going to do, I'm going to design the position of the whole incisor edge of the upper arch. This is my smile curvature. This is the curvature or my reference line that I want that the incisor edge of the whole tooth is going to touch in this area. I know now exactly where do I start to design a central incisor, okay? If I have already some width, you know that you have a proportion for the length of this crown, okay? To have 80% of the proportion, as an example, for the central incisor. So here you can work a little bit in this proportion from 85 to 75%. You're going to work close to that proportion. You're going to have a good result, okay? Let's get the ideal proportion, that is 80%. Just now you are seeing that you are looking for the position of the soft tissue. If I'm going to take soft tissue, or if I'm going to rebuild the soft tissue, just now, just after running for this process, that I make a determination of the right position of the zenith from my patient. And this is exactly what I'm setting this small blue line. What is this small blue line? The zenith position. The zenith is the highest contour of the soft tissue on a crown. And you are seeing that the position of the zenith is not exactly in the center of my square. It's a little to the distal. And we try to design, for aesthetic reasons, the zenith position always a little more distally. When we have class 1 biting with a static smile for the patients, 98% of the crowns have the alignment of the crown, the tooth, for the center of the patient, okay? That is great because you know that the alignment of the root of the crown of the tooth of the patient, you have the white contour of the crown that is going to have or to give this view for you, but the soft tissue contour also play a role on the perception how the tooth is aligned. When you give the contour of the zenith to the distal center of the crown, you're going to have, or you're going to give the impression that this crown or this tooth have alignment to the center of the patient. If you do the opposite, or the opposite, that is placing the zenith to the center of the crown, you're going to have the impression that this crown is for the side of the patient, this way here, okay? And you want to have a better aesthetic view, given exactly this centered alignment of the root, okay? Good. Okay, Ricardo, I get it. I know that I need to identify the incisal edge position and from that have this alignment of the curvature. I know, and I just take note that the proportion of a central incisor is 80%. Now, what is the ideal proportion for the lateral, the canine, the premolar? I need to know that. No, you don't need to know that, okay? Why is that? Because you already are starting to set out the reference lines to design the another tooth. If you have set and designed the central incisors, how is the another reference line? You already have one of them. That is the smile curvature, that you're going to touch the incisal edge of the another crowns here. Contact point, papilla, and zenith position, all these lines is going to have a symmetry or a relationship with the first curvature that you just designed. So the smile curvature taken to the contact point, you see that you have some symmetry. You're going to design the contact point exactly trying to following this ascending curvature. The papilla position, the same thing, you're going to design a curvature that's going to follow that until the end of the mouth corridor. The zenith point, the same thing, you're going to design a curvature that is going to be up until the mouth corridor. The only exception is the lateral incisors, because the lateral incisor is a short crown. So the incisal edge is going to have 1 millimeter or something more apically to not touch this smile curvature. And the cervical margin is going also to have a little more coronal position than this blue alignment. Sometimes you have on the premolar also some short crown with this zenith position a little more coronally. But basically between those lines, you can now design the shape that you intended to give for the patient. A triangular crown, a square crown, a rounded one, the one you think that is suitable for your patient. Usually for crown lengthening, I like to adopt a more triangular shape. Of course, I need to identify also the shape of the crown itself for me to give that for the patient. Good. So I have my design, okay? And now I can make these measurements. How can we do these measurements? We take a measurement in the real on the patient mouth. I took a measurement of a central incisor, okay, is 5 millimeters or 6 millimeters, and I bring this information to the picture of the patient. So I have a rule. I don't have the rule here. Maybe later I'm going to bring in discussion. So I can take different measurements in different position of the picture and take notes. You see that these notes here in red are the distance between the incisal edge and the zenith point. On the patient's mouth, this 10 millimeters is going to give me the reference for my crown lengthening. I have a caliper that I can just make the measurements in the patient's mouth between the incisal edge and the zenith point, and I know exactly where to cut that in the patient's mouth. Okay, how much you're going to bring the incisal edge coronally? You have all the notes here also. You can send this information for the technician, and your technician can do the WhatsApp perfectly understanding how much he needs to increase the incisal edge, okay? So let's start to treat this patient. You see I have a lot of work to do, lot of different specialties. We check for a CBCT scan. Opa, there is something different here. One of the central incisors is a crown over implant. We're going to graft this crown. We need to manage that together with the crown lengthening for the other front tooth. The CBCT scan gives me a good position of the implant. This implant is really centered with the crown. Is not placed to the facial position, to the buccal position. So I can really remove this crown, graft, and have another crown in place. The another CBCT scan image is going to give me exactly how much of the enamel is hidden under the gingival margin, so I know how much I can also do the crown lengthening without expose the root of this patient. This is very important for us before offering for the patient a crown lengthening, because if I imagine that I'm going to take 3 millimeters of soft tissue of gingiva, what am I exposed for this patient? Sometimes there is enamel hidden under these 3 millimeters, but sometimes you imagine to take 3 millimeters and you expose a little bit of enamel and expose a lot of cementum, a lot of the root of the patient, and you have a problem if you're not going to restore this crown, okay? So we have the CBCT scan to really know exactly what I can expose, how much I can expose, and the work I need to do to have the biological width reshape for this patient. The occlusal view for my implant, you see that we lost a lot of volume on this implant. The lateral view gives me exactly this notion that if I want to have a perfect emergence profile for the crown, I need to augment this volume. Otherwise, always my crown is going to have that very rounded emergence profile looking like what? A crown over implant, not a crown over a natural root or a result that seems natural. So we're going to graft and increase this volume. This is the measuring for our crown lengthening. We're going to cut this gingiva. And this is the rule that we use to do this kind of cases. This is my caliper. The caliper is exactly measuring with, like in the central incisors, with 10 millimeters. So I place this caliper, I make a mark on the soft tissue, and I know exactly where to cut with a lot of precision. Using blade, using electroscalpel, any equipment that you are used to do, you can just recontour the soft tissue accordingly with a lot of precision, okay? And of course, after that, you need to think where is the position of the bone crest, because we know that we need from the gingival margin to the bone crest close to 3 millimeters to establish the new biological width position. And there is many ways to reduce the crest if needed. Open the flap and reduce the crest. And lately we have been doing for some patients the reduction with access by the sulcus of the patients using a piezo device to really wear out the bone crest through the sulcus. But just let me just address something here. It's just possible for me to do this crown lengthening through the sulcus when I have a very thin thickness of the bone crest, less than 1 millimeter. Because if I try to do this work with the bone crest thicker than 1 millimeter, you're going to be lost what we are wearing out. You do not know if you are wearing out cortical, cancellous bone, or even the root of the patient. And your work is going to deliver a crest that have a step on the crest. Probably the bone is going to be back a little bit. You cannot shape that easily, cannot give the anatomy to the bone. So it's just possible to do that really when I have a very thin biotype of the bone, as you have been seeing on the CBCT scan. So from 1 millimeter that I have of the new zenith position to the crest, we air out the bone until I get to the 3 millimeters that was necessary for my biological reasons. In the central incisors, we take out the crown. What we are doing here, I'm open the space for my soft tissue graft, okay? I don't want at the end of the surgery to compress my connective tissue. Connective tissue can be compressed with sutures or with crowns and so on, because the connective tissue that you have, the collagen fibers, if you compress that, you're going to diminish the possibility for nourishment of this graft on the early stage of the surgery. So you cannot compress that, okay? The nourishment of a connective tissue in the beginning, it's happening by osmosis. So you have the extracellular liquid moving from one tissue to the connective tissue by difference in the graduation of this extracellular content. And if you compress the graft, you cannot have this movement happen easily. And you're going to compromise maybe how much of the connective tissue is going to survive in the area, okay? So we prepare the recipient bed and you're going to graft a connective tissue in place, crown lengthening done, connective tissue in place, crown relief on the cervical margin, and we need to wait for the body to do its part. So I have here maybe 1-2 weeks after the surgical approach. I'm not sure exactly how much. And this is the rule that we bring from the picture to make the measurements on from the real to the picture. You need to make a calibration to have the measurements from the real life to the picture with a lot of precision, okay? And from that point on, we move this patient for the restorative work. So that information that we have before went to a WhatsApp. the technician send us the WhatsApp with the new position of the incisal edge. On the cast, we have exactly a silicone guide with this new position. So we remove the old restorative work and we position the silicone guide in order to give me the restorative work in the front zone. It was done with composites with this new smile curvature edge. Okay, restorative work almost finished. The soft tissue almost mature. What I need to do? I need still to do the final crown for the central incisors. You see that we graft, we achieve even a little more volume that is needed. So the central incisors over the implant is shorter, is square. We need to condition this shape. How can we do that? And you're going to do that on a cast, okay? Is way the more precise technique that you can use to modify the soft tissue contour is modifying the contour on a cast. So you take a regular impression of your soft tissue and you see the two central incisors here, one lower, one higher, and you're going to really make the sculpture of the new soft tissue position on this cast. And after that, I'm going to unscrew the temporary, screw in position, and you see the difference. You see the gap, and you're going to fill the gap with a composite or acrylic according to the material that you have from your temporary. And you're going to make the refinement of your crown, and now you're going to move back the crown in place, okay? Let me just make some information here. Nowadays, usually we apply a concave emergence profile, okay? Not a convex emergence profile. With a convex emergence profile, you can compromise the stability of your soft tissue on the long run, okay? There is many issues that we can discuss on this picture here. I think Alberto Miselli has brought a very nice concept that is the umbrella concept, that is exactly what summarized this very concave emergence profile, because I want surrounded my crown, surrounded my implant to have really soft tissue. I have natural tissue. I don't want to occupy and fill this place with ceramic, with composite or artificial material, because it's exactly the thickness of the soft tissue that is going to protect and is going to establish a healthy and stable peri-implant tissue, okay? So this is my temporary being screwed back. You see that it's going to push, moving the soft tissue apically. This is just after push the tissue. I'm going to wait a little bit until this tissue to get mature. And after, on this case, 2 or 3 weeks, I'm going to give or do the final impression, okay? You see that we already have a very nice balanced contour. If you conditioning well the soft tissue, you want to deliver this information for the technician very precisely to have the final crown with no difference what you have achieved. You don't want that the final crown is going to have something different that you've done. So how you can have this precision given as information for your technician? We're going to just make a copy of the emergence profile that you have achieved on this temporary on the final cast. So how can you do that? We have in our temporary, we can just mark with a crayon or something like that, the cervical margin contour, and you're going to unscrew your temporary, you're going to screw the analog, and you're going to wrap around this crown and the analog, the silicone all over that, okay? Usually people using a Dapin dish, and I do not like to do that, because on the silicone on the Dapin dish, sometimes when you try to unscrew the crown, the analog just start to twist in position. So I use a plier, a hemostatic plier, to hold the analog in position, and I wrap it around everything so the analog is not going to twist and to turn around because the plier is holding it in position. So you're going to cut the silicone, unscrew this crown away, and you're going to fix the impression post in place. What you're going to do, around this space, you're going to use flowable resin or pattern resin to make a copy exactly of the temporary. What you are doing here, you are customizing your impression post according to the similarity of your temporary. This shape here is exactly the shape of the temporary. When you are doing your impression, what the information from your cast is exactly the information that you have on your temporary. So you can do the impression here, this beautiful shape you're going to deliver to the technician, and your technician is going to respect this emergence profile, the zenith position, to have exactly preserve what you have achieved. So this is the final treatment, just for us to understand how far we move this case, but it's not complicated because as a good treatment plan from the beginning, I could communicate with everybody from my team, the technician, the guy that did the restorative work, as myself doing the surgical part of the treatment, everybody talking the same information, the same tune to deliver that for the patient. Okay? So we have some space now to have some questions, and we're going to open some discussion what we brought so far. So I'm going to unshare my screen. Okay. So I think everybody can see each other here.
Thank you
Good.
so much, dear Ricardo, for a wonderful case presentation. I believe all our moderators have to unmute themselves, and I believe this you have a minimally invasive approach towards the that you try to work around in the patient's mouth with a minimally invasive approach in the sense that first you like to do the digital smile design. And I think the credit goes to Dr. Christian Kochman that
Yeah.
he has brought this technique into and in India. I was getting a lot of appreciation from Dr. Rajiv Verma sir, who has brought this technique DSD in India, and I got a chance to do the DSD. Uh, but it is so difficult to for Indian patients when we are talking about Indian patients or the Asian population. uh, they do not have so much of patience that they keep on coming for the follow. So first of all, I would like to invite Dr. Ashvini Padhye to come up with some discussion.
So I think Dr. Sandeep, from where we've come, things are changing today. It's not as bad, I would say, as it used to be. And we have, yes, we do have different, sects of patients, but there are those who are ready to put in that kind of time and effort, and they do appreciate the time and effort that you're putting into to actually recreating this. So in typically I would be advising this patient after assessing the patient and what are the aesthetic demands of the patient, because I don't want to spend this kind of time and effort on a patient who is not wanting it himself or is not going to appreciate it at the end of the day, because it's a lot of time and effort that you put in. And then when you follow the protocols that Dr. Kern has given, planning, I really appreciated the way he has explained the whole planning, the incisal edge position, which is the first step to start off with in any case like this, which is so overlooked by most clinicians around. So that is perfect. And then you get on to the balance of the white and the pink once your zenith positions are established. It's amazing. And once you do that, the end result is something that you can go back home and be happy and sleep in peace with. So fantastic way that you put it ahead, Dr. Khan. Super.
Thank you so much, Dr. Ashwini. Dr. Rita, do you have anything to discuss or ask? Dr. Ricardo?
Okay, first of all, let me compliment on each and every picture. It talks a volume about your passion, your precision. Every time I see your cases, it just does not stop amazing me. And I feel like why I'm not able to do these things, because you make it so simple. I really liked the investment in time that you make in the pictures. Normally as periodontists or prosthodontist, we either work on the cast or in the chair side, in the patients. But the amount of time that you seem to be investing in the photographs, and where you said that self-development is very necessary, I think that is the most important take-home message from this part, the first part. And I was really touched by when I saw your case where you had recession, and I was so tempted to do the connective tissue, and then you said you did not have to do any surgery in that patient. I'm waiting to see that case. So I think a lot of learnings from you, Ricardo, as always. Thank you so much, and I think we will be discussing in the later. Over to Radhika.
Yeah, hi, Radhika. As a prosthodontist, what do you think about the case which was presented right now by Dr. Ricardo? So, what was your perception?
I think as a prosthodontist, I have much more to say than the periodontist, really. I absolutely loved what Dr. Kern did. And I completely disagree with you, Sandeep. A lot of patients today, when they come to you, are paying much more to us. When we do it the way Dr. Kern has shown us, before we go ahead and do the permanent restoration for the patient exactly knows what he's getting into. And more than the patient, you know as to whether you want to make any amendments at the temporary stage. As in, I'm talking about the crown or the veneer stage. Of course, planning is the number one condition to do any kind of a smile design procedure. The first reason why I wanted and why I joined the master classes of Dr. Autozod and Mark Rosella was because the pink and the white, they're irreplaceable. They both go hand in hand. If you don't know one, you can't do the other. I'm sure Dr. Kern would agree with me. If he didn't study occlusion or if he didn't study the percentage of the height of the crowns or the width of the crowns or the zenith of the crowns, his surgery would be incomplete. So planning a case before you go ahead and actually do a case is fantastic. It actually reduces a lot of your time with the patient and lab and with the clinic. So I think it's a fantastic way of going about it. Dr. Kern, thank you so much, because a lot of us can now start practicing the way you're actually teaching us to do. You'll soon hear a lot from me and hopefully see me soon.
I would like to mention one more thing, Dr. Radhika. I was talking in general about the Indian population. There are certain class of patients, those who understand, and there are more of those patients, those who just don't want all these kind of procedures.
No, Sandeep, you'll be
where yeah,
surprised. It's
yeah, yeah,
changing.
I know, I know, I
It
know.
is the way you present the case to a patient.
No, I know that, but there are the percentage is very low. Let me tell you, the percentage is very low because you are practicing in a capital city of India. Dr. Ashvini is practicing in Mumbai. Dr. Rita is practicing in the capital city of Nepal. But I'm talking in general that what people have to face. So the only problem is there that we as a dentist, we have to make them understand, make them, we have to convince them and we have to educate them, and that is how things will change. And another thing is that the DST, the idea of DST coming down to India, it is way back Dr. Rajiv Verma brought in this thing, but still not taking up much. People do go and attend the workshops, but then bringing back that practice into their day-to-day practice, it's like little tough. Even I attended, as I said, and now the another biggest concept which he talked about after Christian Coachman's digital smile designing is Dr. Alberto Miseli's umbrella concept.
Mhm.
Earlier, because we had Dr. Alberto Miseli with us a few days back, and Dr. Alberto Zovares and George Paps, who has come up with the Cervico VPI system, creating a customized emergence profile. Earlier, he strictly said that do not use anything which is very wide. It has to be constricted. The temporary abutment has to be very narrow abutment. And this is what he talked about, Dr. Ricardo, that you have to think about it. The emergence has to be narrow initially so that you bring in a lot of soft tissue around. So umbrella concept is another thing which we need to incorporate into our practice, whether we are periodontist or not. So
Just a
these two.
question, Dr. Kern. When you do a surgical crown lengthening, as in you're also doing the osteotomy alongside, how long do you actually wait for healing before you do a permanent prosthesis? Before you deliver a permanent prosthesis, rather?
Okay, it's a very good question. Uh, Usually we plan it, the case very precisely, and we try to execute it very precisely also, okay? We understand that we work with different patients with different phenotypes of soft tissue. So I have thick and thin soft tissue. And when I approach this case, I treat it different. If I need to open the flap in a thick phenotype, the incision is beveled because I want at the end of the surgery not to have the cervical margin too thick. In a thin phenotype, no beveling. I'm going to end up with the soft tissue preserved because if I bevel the soft tissue, I'm going to have some recession, receding at the end. The biological width itself, we treat it differently also. We learn for many different works, the biological width it's 2.85, 86%, one work, another one, but everybody's different. It's an average. And I need to understand that. So I give a variation of the distance. So some people with thick phenotype, we go to 3.5 millimeters. Very thin phenotypes, 2.5 millimeters. During the procedure, the whole procedure, I use the same caliper to mark the gingival margin, cut the gingiva, but also to measuring the bone crest. If I want to give for these patients 3.5 millimeters, I'm going to just add 3.5 from the first measuring of the margin, because I'm going to cut the bone crest exactly as I planned before. Because the flap, as the flap moves, you're not sure exactly if you are giving 3 millimeters. What happened that the result is very stable. What I have in the first week, 1 month, 2 months, 3 months, it's stable, completely stable. What I see on the pictures, that's why we take a lot of pictures to compare and see what we are doing is right or not. And okay, to get to answer you, if I need in a crown lengthening to do some restorative work that is not going to be under the inside the sulcus of the patient, usually I have a very wide crown or root with no different in the color. We can start the restorative work with 40, 50 days, okay? But if I have like a crown and a root that I need to do the impression intrasulcular, I need to hide a color compromised root, and this impression under the sulcus is like a bit of traumatic. I need to wait the completely maturation of this tissue. And that is going to happen after 80 days. So 3 months for you to go to the final treatment. And if you build up everything right, the tissue, even you doing an impression a little more traumatic, the tissue is going to handle, going to be stable for you not to have any bad outcome, any surprise. Okay, so you can anticipate a little bit. If you want to be sure 100% of the case, wait 3 months and be precise on the crown lengthening procedures because you don't want changing on what you are building.
Thank you.
There is a very small point, the question that when you design the temporary prosthesis, you add up the composites, flowable composites, to give it a concave profile and all those things. So, do you treat that composite, because there is always a leaching process which can harm the soft tissue? So, do you do any kind of treatment to your temporary prosthesis by heating it, keeping it in a warm hot bath, or because this is very small question by the general dental surgeons. There is one question which has been asked, so that is why I'm coming to this point. Do you do any kind of treatment to your temporary prosthesis?
No, usually on the temporary, I like to use acrylic a lot. I work a lot with acrylic. So many of the case that we are conditioning the soft tissue, I'm working with acrylic. And on acrylic, on the polymerization, we heaten up that in water to have a better polymerization, more a smooth surface, and a lot of polishment. With a flowable composite resin, usually I'm applying or realign a ceramic crown. That's this example, we use the old ceramic from the patient, and we treat the surface of the ceramic, apply the specific primer, use the flowable resin, but nothing more specific than a good polymerization and a good polishment of the surface of the resin on that. Okay, that's mainly this approach. We avoid to bring this material, composite and acrylic, in a degree much closer to the implant platform. This is a good discussion, a large discussion, but I always want to build up a biologic area over the implant platform. That means to apply a abutment or a material that is biocompatible. So my transmucosa neck of my abutment of 2.5, I want titanium exposed. I want to have zirconia or PEEK abutment to have a belt of biocompatible material available for the connective tissue to seal the body, to build up the biological width over the implant platform. So I'm avoid to bring this no biocompatible material close to that area. So I always work currently to that area. Yeah.
Thank you so much. Right now, we do not have any more questions from the audience, so we can move to the part 2.
Okay, good.
Yeah.
So let's go here. Oh, sorry. I need to share. Okay. Okay, that's good. You are seeing the screen?
Yes, we can see the screen. Yeah.
Okay, I'm going to present two cases here. And more or less, the first case is the sequence to the third case, okay? To understand some basic principle on the design of the soft tissue. And on the third case, you're going to bring some surgical knowledge, how to deal with the flaps and so on. So this is a case that they have completely compromised roots for this patient. This patient stood with this temporary for more than 5 years, tried to treat this root channels and a lot of work. When he came to us, I think 80% of the roots here was completely compromised. I don't have the chance to save. And the first treatment that this patient received as alternative for the natural roots was to do like a Al-on 4 treatment or Al-on 6 treatment. It means for a patient like this one that the smile line is a high smile line, showing the encounter of the crown with the soft tissue. It means to open a huge flap, to air out the bone, and to have a prosthesis that the encounter of the prosthesis with the soft tissue is going to be under the lower lip of the patients. So I think that biologically speaking is taking a lot of tissue of the patient, wearing a lot of bone, cutting a lot of gingiva for this patient. And on this kind of relationship between crown, lips, and what I'm going to have in the final treatment for the patient, the position of the crown, we face here the opportunity to preserve the soft tissue as much as we can. As you see, if I have this soft tissue preserved close to this design, I can offer for this patient a crown or a bridge free from pink ceramic. So what we delivered for this patient was extraction, full extraction, but not open flap. We're going to preserve each of this socket the best way as we can. We can even use in some connective tissue graft in some areas to build up and to maintain the perfect architecture for the pink contour for this patient, okay? We're going to discuss some surgical approach in the next case. For in this case here, we have the treatment plan, we have the temporary ready in our hands, with the position of the implants already discussed pretty well. It's going to be in the central premolars and molars, and we extract all the upper roots of the patient, and we fix 6 implants, and we realign the crown, sealing all those sockets entrance. So my temporary is always responsible to preserve the soft tissue contour. And I really, really think that the temporary plays a huge role in the soft tissue socket preservation, not just biomaterial, not just connective tissue and so on. The temporary is amazing to play this role and to preserve the tissue. So this was 10 days after that surgery. It's a long surgery. It takes us like 4 hours to extract the tooth, fix the implants, fill the gap with biomaterial, realign the temporary. But the result for the patient, it's amazing because the patient just leave the office with the crowns completely sealing the socket entrance. Is a very atraumatic procedure for the patient, and the recovery is even more beautiful. So 10 days after that, and I have this kind of result for my patient. All the tissue preserved, the volume and so on. Okay, what I'm going to discuss in this case here is to start to bring to you how to make very precise impression for full arches, okay? Or for at least 3, 4 crowns over implant that you have customized the soft tissue, okay? So how can we do that? Do you remember the last case? I have a central incisor. We unscrew the central incisors, screw over the analog, and we wrap it around silicone on that. Okay, why is that? To have my impression post customized with the same shape. How can I do when a full arch? How can I customize the impression post of a full arch? So we have a technique that we call gingival impression index. Okay, it's a very, very simple technique, very interesting for us to have exactly all this contour here impressed with a lot of precision. So what we do is we make an impression with alginate, with this crown is still screwed in position. The crown is still screwed. I came with my alginate, make the impression, take the impression away. And I'm going to unscrew the temporary. And now I'm going to have the analogs screwed on the temporaries back. And this set, I'm going to squeeze inside the impression of alginate. What you have here, you create something very similar that we are creating in the first case. We are creating a base, a cast, to make customization of impression post. In this case here, we created this base using a kind of silicone. This silicone is a dye silicone, is a silicone proper to have cast made from this material. So we pour this silicone inside this impression, and the nice part of the silicone is in 3 minutes it gets set. So you can really bring the temporary back from the impression and deliver the temporary in the patient's mouth. Ricardo, can we use here gypsum? You can use that, but be concerned in one thing. When you have the soft tissue all customized and you let this area without the temporary for more than 10, 15 minutes, the soft tissue starts to change the position. And you try to move back the temporary compress a lot, the soft tissue cause a lot of pain for the patient. So you need to give completely anesthesia in the whole maxilla to screw back the temporary. And with this material, so the gypsum take half an hour, 45 minutes for me to deliver back this temporary for the patient. And I want to have again time, be faster, and be nicer with my patient. So we use this material. This one is from Voco, is 3 minutes is set. Totally time in 7 minutes, I'm delivering back the temporary for my patient. So I can screw the temporary back and okay, the patient now can rest or go home because I have here the base for me to realign the impression post. Okay, this is the idea. This is not the impression for the technician because this material has some distortion on that. Okay, I need to do another kind of impression because it's a long bridge. I don't have any fraction of millimeter of distortion on the impression. But this cast here is going to help me to customize the impression post. Okay, so we unscrew the temporary and I have here the cast for me to customize the impression post. It's the same thing. We screw the impression post and around the impression post, we have the pattern resin around every pontic, every emergence profile, every papilla. So all the information of the implant position in the soft tissue is on this index here, okay? And once more, we need to be concerned of the distortion of this material during set. So the pattern resin is a very good material with a very low distortion, but even though I have some distortion. So this impression post here, before I move back in the patient's mouth, we need to cut this, index in small pieces to compensate the distortion of the material. So you have a diamond disc, very thin, and you're going to split in many pieces my index. Usually, I don't have together in one piece 2 implants. We just is going to split every implant in this position. You can have 1 implant and 1 pontic area on the same piece for you to screw back in the patient's mouth, okay? So we move piece by piece, screw in the patient's mouth, and on the patient mouth, I'm going to bond together this bridge here, and now I have exactly this arrangement here. So I'm bonding all the pieces together, okay, good, and I can take the impression of this index now, okay? You can make an impression with a silicone. We use a closed tray technique for this, this step of the impression. I do not use an open tray technique. I'm really very afraid of open tray technique not afraid because the technique do not work. I'm afraid of doing that, because for me it's very stressful to really find the holes of the tray with the long screws on the impression post. I never find it. Okay, I never miss one hole. I need to do it again. It's stressful for me. And here, this impression post, we change a long screw for a short one. So the screw is hidden on this area here. It means that I can make the impression, remove the impression, and just after that, unscrew the impression post, the impression index from position, screw the analogs, and move this whole set inside the impression. Okay, so it's very precise, very stable. All the information I needed is on this index, the position of the implant, the soft tissue contour, everything on this index. Okay, let me just point in something very important here. When you do an impression of soft tissue, you must do this impression in a hard material. Okay, flowable resin or pattern resin, you're going to do in a hard material. You cannot do this impression with silicone, because silicone is going to push the soft tissue contour, is going to make a deformation of the anatomy of the compression of the silicone, and you are going to give the wrong information for your technician. Okay, so I have here the final work, and very precise. The contour is maintained from what we have from our temporary, and very natural when I talk about the proportion of this crown comparing to the proportion of a natural crown, because we are very concerned to preserve the soft tissue in position with this patient. Okay, so now that you understand a little bit of the impression index, we're going to bring a very long case when the index was used for not just making the impression, but also to customize and condition the soft tissue. Okay, so this is the case. This case, again, very high smile line. I need to make some decisions in cases like this one. I need to preserve the soft tissue, or in case of implant, open huge flap, wear the bone, and hide everything under the lip. Doing hour on 4, hour on 6 is going to be fast, it's going to be easier, cheaper, and you need to discuss that with your patient. Some patients deserve that, some patients do not deserve. Some patients give value in this kind of treatment, some patients do not give value. Some patients, okay, Ricardo, I don't want a long treatment, I want to have as fast as possible a solution for me. And you're going to open a flap, take it out the bone, hour on 4, hour on 6, in 2 days the patient with the final bridge, and keep going that. But it's different when you have a bridge with a lot of artificial gingiva, the way the patient's clean and so on, then when you have the example as we are showing here. And believe me, we until nowadays do much more hour on 4, hour on 6 than this kind of treatment. So the patient, we choose the patients, the patient must to understand exactly how much work that must give the value for this kind of treatment. Okay, so what are you going to do here? I have many problems for this patient here. If do a treatment plan for these patients, you can see the central incisors needing a crown lengthening. If you see on the mouth corridor, maybe the premolar are a little lower. If I can move it up, I'm going to move it up. That needs some modification on the lower arch also. I have here on the 13, a canine that's a little palately. If I want to bring more volume to this canine, maybe you see that I don't have much volume on the soft tissue for the proper emergence profile. And I have also on the opposite canine, a very long canine. So I need not just give volume of the soft tissue, I need to bring this soft tissue cornely. So a vertical and horizontal defect that I need to fix, okay? Good. And the alignment of the smile curvature for this patient. So this is one kind of defect. I'm going to soft tissue graft this area to gain volume. In the opposite side, soft tissue graft to gain horizontal and vertical volume also, and crown lengthening on the anterior zone. Always concern on the long axis of the patient and so on. What is the problem involving in this case? I have much more problem than the surface showing us. I have here 4 fistulas. A lot of work, okay? So I have here on the first premolar, the 14, a fracture, an endoperi infection. On this canine, the 13, I have a very large periimplantitis. On one of the central incisors, I have a fracture, and all the incisors is a breach. The lateral are pontics, and I have on the central incisors natural root. One of them is a fracture. The 23 is an implant, is healthy implant, but with a very large abutment, buccally placed. So, and I have a gap between the crown and the abutment, so I have a fistula on that. So I have a lot of troubles to work. So I design here and summarize a little bit what we need to face. Unfortunately, this patient for the insurance took some part of the documentation, the best documentation we had. So I need to design that, but I still have some x-ray doing the process here for us to follow up. So I have many problems, and I just end up with just 2 natural crowns, roots, to make a rehabilitation of this patient. And thinking on the solution, we decided to go a full arch implant rehabilitation, just letting 1 molar natural root apart from this area. So we extract, and you're going to split the surgical approach in 3 different approaches, okay? First, second, and third surgery to solve this patient. Good. Let me just think here on the sequence. Okay, the first surgery was immediate implant placement, not a big deal. Extraction, 2 implant, filling the gap. We did the crown lengthening and realigned the temporary, doing socket preservation, not a big deal. Second surgery, I had a very long old implant to take it out. It was a 6.5 per 16 long implant. I was pretty afraid what is going to happen trying to remove this implant. If I have some fracture of the implant, the volume fracture of the bone, and the defect that we need to treat. So I started the surgery with all the material necessary to rebuild this area and so on. And the idea was to fix 2 implants, one tilted in the second premolar, and then another one could be fixed in the same place, a longer implant, palatal approach. It was possible to fix and to make the anchorage in the canine pilar here. Otherwise, you're going to move this implant to the lateral position, okay? Happily, when I tried to remove this implant, the contra torque necessary was less than 20 newtons. So I just start to turn the wrench, and the implant just came out. That make my life much easier. So we fixed the 2 implants in place, the tilt one and the position of the canine. We installed the abutments and the temporary copings. We realigned our temporary in place, and with the temporary ready, we build up a little bit of, we fill the gap with biomaterial, a small collagen membrane on this buccal margin of the alveoli of the canine, and on the canine to the lateral, a small connective tissue graft was tunneling in a coronal position for us to increase and to recover the volume that was lost long before. Okay, so this is the post-op for our patient. Temporary is back, and 3 weeks of recovering of the patient. The tissue was showing a health response, so we can move to the another approach. We have the first and the second surgery already done, and the time for me to move to the third surgery, okay? So this is the position. So the third surgery, we remove the crown, we install the temporary, we have a new abutment in place, and I have this situation before the surgery, okay? So completely temporarization of the arch now, and I need to do the surgery to augment this area. This is my occlusal view here. You see the defect, the volume of the defect that you have. The new abutment already in the position on the alignment of the tooth on this arch. When you try to rebuild soft tissue in old implant, we need to think on the position of this restorative work. When I talk about the restorative work, we need to think the position of the implant, we need to think in the position of the abutment and the position of the crown, okay? Sometimes the position of the crown is not in the right position, but in the abutment, in the implant are okay. Sometimes the crown and the abutment are not okay, and you just can remodeling these two without removing the implant. Sometimes the implant is not okay, so you need to remove the implant. And which is this position? When you see here, this white line here, it is the buccal contour of the whole soft tissue. It's impossible for me, or very difficult for me, to try to create some soft tissue if I have one of these three parts of my restorative work, crown, abutment, or implant, close or buccally to this line. I need to have this restorative piece inside this arch. If you looking for the occlusal line of your arch, the ideal position is to have this restorative work on this alignment or a little more palatally, okay? So when I remove the old crown that was with a large emergence profile, and I change the abutment, I see this new abutment completely aligned with the occlusal alignment of this arch. It's possible for me to augment and to bring this soft tissue on this area. So it's the first stage. If I intended to graft and do not manage the prosthetical position, I'm going to have failure for my treatment, okay? So here we approach to do like a coronal advanced flap, and you're going to graft on this area. And we start an incision on the top of the crest of this area here. And I'm going to bring some information how to manage a little bit of the flap when you are intending to graft, okay? Because we read the tissue in different ways. According to the tissue I'm working, I'm going to play with the tissue in different ways. I'm going to do a small design here, a small drawing, in order for us to try to understand a little bit. And I think that is a very, very nice information for us to discuss, okay? So case like this one, you have the crest here. So I have the palatal side, the buccal side here, and I have my soft tissue. From the palatal side, top of the crest, when you are turning to the buccal side, what you have here? On the top of the crest, you have keratinized tissue. Here you have the mucogingival line. So is the encounter of the keratinized tissue with the mucosa, right? What you have under the mucosa? Under the mucosa, you have the muscles. So muscles, okay, let's stay in black, okay? Good. We treat this tissue in different way when we are thinking in graft this area. And for this technique, we start with the incision on the top of the crest, and you're going to go close to the bone contour here, okay? We avoid to bring this incision more palatally. I'm going to discuss that a little later with you, okay? So I'm going to bring this incision close to the bone crest here until I get to the periosteum. So the periosteum is covering all the bone contour here on the keratinizide line and also on the muscular attachment. So the muscles are attaching on this area here. From this incision, I'm going to turn the blade following the contour of this periosteum or following this contour of this bone crest. This way, as the bone is turning and moving the direction, you're going to move the direction of your incision also. Sometimes you're going to bump the tip of your blade and damage a little bit of the periosteum here, but you're going to try to let all the volume that is possible on the surface of the flap, okay? Until you get close to the mucogingival line. When you are close to the mucogingival line, a little apically, what you're going to find is the muscular attachment to the periosteum. And on this area here, you're going to change the direction of your incision. Instead of doing an incision close to the periosteum, deep on the tissue, following the contour of the bone, you're going to change this incision to the surface, close to the surface of the mucosa, very close to the surface, on this direction now, okay? And you're going to detach completely the mucosa from the muscles. Why is this difference between one approach and another one? When you do this kind of incision close to the periosteum, Ricardo, I'm not going to damage the blood flow, the vessels. No, you're not going to promote that, because you see here, when you cut the tissue on the mucosa, and even when working with the blade close to the surface, sometimes you see your blade working under the surface. You see shining through the tissue, the blade working. And even being so close to the surface, you not cut the main blood vessels of this tissue, because the main blood vessels of this tissue, they run close to the surface, and you're not going to damage this area. But on the keratinizide zone is completely different, because here on the keratinizide zone, what you have here on the anatomy, you have the keratin layer. Under the keratin layer, you have a very thick epithelium layer with this kind of projection. And I don't have the main blood vessels running on the epithelium layer. They going to run inside the connective tissue layer. It means that if you split this area close to the surface, the keratinizide tissue, if you split close to the surface, you're going to cut the main blood vessels that running here. So your flap, there is no blood supply on your flap, and you're going to have some necrosis of your flap, because you just cut out the supply and nourishment from this part of the flap. That's why we make a deep splitting here and a superficial splitting on this area on the mucosa. Ricardo, why you do not cut in the middle of the muscles here? Because there is a reason here. You don't have all the time to explain, but let me tell you something. When you are grafting for 1.5 millimeters, 2 millimeters of connective tissue for a receding root, you need to nourish and think that you need to nourish 1.5 millimeter in thick of connective tissue. So that is not so complicated to have. If you lay down the connective tissue over the root, there's no nourishment from the ground. But if you cover with the flap in contact with the connective tissue can nourish and maintain this graft health and stable. But in case like this one here, the idea is not to bring home 1.5, 2 millimeters of connective tissue graft. I want to have a chunk of connective tissue, 5, 6 millimeters, how you going to nourish this connective tissue of 5 mm in thick. If you just lay down this connective tissue in one surface that there's no nourishment, you're going to lose a lot of connective tissue because you're not going to have this connective tissue surviving. You need to have all the surface of the connective tissue with nourishment from its cells, from the tissue that you just brought in. It means to have on the ground a good and healthy periosteum, not titanium, not root, not abutment, not bone grafting, because bone grafting is not going to nourish my connective tissue, not even the bone of the cortical layer here. I want to have in the ground periosteum, okay? And I want to have on the surface a healthy and well-treated flap to nourish it from the surface, my connective tissue also. And I want to have this arrangement is stable, mechanically stable. As you saw here, the incision contoured deep on the bone and here went close to the surface, completely taking the muscles from this flap. What is the idea? To have a flap that has no interference from muscles on the healing. So I have the muscles completely unattached to this flap, so the muscle is not going to keep the pull and moving from my graft, okay? So you're going to split it. And when you do splitting, this way you have a nice releasing of your flap, a passive closure of the flap, no muscular movement on this flap here. And if you have on this area the muscle attachment close to the crest, you can do a third incision, that is an incision close to the ground, cutting the muscles from the periosteum to make more room for your connective tissue here, to lay your connective tissue on this area, and you're not going to have muscles attaching, not on the surface, not on the ground. The muscle is going to be moved way apically without promoting interference of your connective tissue. This is a very short summarize of the technique that we can approach in case like this one here. So just for me to bring a little of the view, how we treat different, the different, because if you understand the anatomy and you know how is the anatomy, the histology of the tissue, it makes sense the way on the area that you're going to split, the thickness, when you're going to cut, and so on, okay? So here, it's more or less the quick design, what I have drawn before. So first part of the incision is following the bone contour. Second incision is close to the mucosa. And of course, the blood flows, it's what the matter. It's what we thought about to design this kind of incision, okay? And here you see a blade working close to the surface. You see the blade here, and you see all the blood vessels on the top of the surface, completely preserved, okay? So release, we test the releasing of this area, of this graft, and I have my connective tissue being tested in position. We harvest a very large connective tissue from the tuberosity. On this picture, you still have the epithelium from the top of the tuberosity on the graft. Of course, I need to take this epithelium layer from this area. Here is the main sources of the connective tissue. Every different source of the connective tissue has different characteristics for us to work. We need to understand that also. So it's completely different, the content, the cellular content, and the extracellular matrix that we have in these different kind of connective tissue. So we took from the tuberosity, when you have a high content of collagen fibers, very stable connective tissue, but we need to nourish all this connective tissue very well. We work and we shape the size of the connective tissue in order to fit properly to our defect. If you remember, the occlusal view of the defect is a small defect from the second premolar to the lateral premolar. As I go into the center of the defect, I have an increase in the thickness. Né? So exactly we beveled the border of this graft to achieve a similar anatomy of the graft. So we just test the position of my connective tissue, and here is something that you must do always, every time that you have the chance to fit if the size or the recipient area was well prepared before trying to do sutures. You must do that. If your connective tissue struggle to get in position, it means that you need to enlarge the area, prepare better this area to have primary fit and stable the connective tissue, and the connective tissue must just stay there without you need to compress with the plier or bring sutures in place. Okay, this is the one of the rules you need to understand. Okay, sutures on this area. All the sutures must to bring a stability of the connective tissue against the ground, okay, against the recipient area. I do not give one single sutures from the flap to the connective tissue, try to do a stabilization of that. Why is that? From all the parts that you are building up, the more movable is the flap. So you cannot use the flap to try to make the stabilization of your connective tissue. So that's why all the sutures, the horizontal, vertical matters are given to bring the connective tissue stable against the ground. Just after have the connective tissue well stable, that you're going to be concerned to bring the flap over. Okay, so these are the basic sutures on this graft, and now the flap over everything. When so this is the beginning, so this is the post-op for the patient, and from here the beginning for the post-op, we still work a little bit on the emergence profile of my temporary, give a very thin emergence profile, not to compress my connective tissue. We need to go or wait that to heal. And here, I'm not sure how long was this picture, but if you build everything stable, well nourished, the connective tissue is going to stay there, is going to survive, okay? If you not take care, what's going to happen? You bring a very large connective tissue, 5 millimeters thick, 6, and maybe just half is going to survive. Okay, 3, oh, that's good. Is still a good result, but maybe is not the result that you need to solve the patient's problem. So this surgery, it's with a lot of care for small details. All the small details here is going to influence the success of your surgery, okay? So I have here the final contour of my soft tissue, a very nice fatty connective tissue all around the arch, but it's crazy, it's not organized. The shape and the anatomy of this, all this surgery that you build up is not good. I need to organize that. I need to make the contour of the temporary exactly the way I need for the final crown. I need now to customize all the soft tissue, condition all the soft tissue. How can we do that? Okay, Ricardo, you show in the first case that you work on the cast to modify on the cast, because if you try to do conditioning on this case, on the patient's mouth, is going to be crazy. You're going to quit dentistry. You're going away, never going back to the office. So you need to have an easy way to do that, okay? So we have the tool for do this kind of treatment. Do you remember the gingival impression index, the red stuff I just present to you? So we're going to use exactly that tool to make the condition. The gingival impression index was produced in a cast from silicone. And is exactly what you're going to do here. You're going to make the impression of alginate, remove, we're going to move the temporary in, and you're going to have that silicone cast. And before make the gingival impression index, we're going to shape on the cast exactly the contour that we need to give for this case, okay? So let's see the sequence. This was my initial treatment plan. These are the modification I need to give on the soft tissue in order to have that arranged. These red areas is exactly where I want to push and move and conditioning the soft tissue. So I make the impression with alginate, remove the impression, unscrew the temporary, bring the analogs on this temporary in place, and I have pour inside the silicone for my conditioning cast, okay? So this example is from another case, just for you to see how is the sequence to make the cast, okay? So inside the alginate, we fix and move back the temporary with the analogs, and in 3 minutes, we have the cast from silicone ready. So I unscrew my temporary, and this temporary can move back to the patient's mouth. What I'm going to do now on this cast of silicone, I'm going to do exactly the modification I had planned before. So this red modification, if I see that on my cast, what I'm going to do, I'm going to trim the cast, just wearing out a pontique, emergence profile, a zenith point, or the central incisors. I'm just going to change exactly with these measurements, okay? So I can control all these modifications. We're going precisely measure how much we are taking from the silicone. And just now I'm going to customize my impression post, producing what we call impression index for this case, okay? You are starting to think now, okay, Ricardo, when you try to move this impression index in the patient's mouth, what is going to happen? Pressure, a lot of pressure. There is some places here, like in the lateral incisors, that is too much pressure. And of course, I did all this surgery. I know what is there. And I need to have the proper approach to get the index fitted. If I go and just compress 1-2 millimeters of the soft tissue in the central incisors to have zenith, you just screw your impression post in the position, and the gingival margin is going to move up. But in the lateral incisors, I maybe need to open a flap, wear out the bone, or I need to trim the gingival margin with a high-speed burr or another technique to open room for this area. So in my gingival index, we cut out the pieces. This is the way we produce the gingival index. So we are producing and building up the index in position. And this is the beauty of the thing. So it's a perfect copy of the emergence profile, very precise, okay? So this is the index. We cut in pieces. Now I need to be concerned in move back all the pieces in place. I had here already the central incisors in place. You see it's just the index. You screw easily, no problem. The lateral incisors, what I need to do? In this case, I need to cut the center of the crest, open the space, move the buccal flap from the palatal one, and we have the space from the pontic to be shaped and screw. The nice part to have pieces is that you can feel the compression, you can see the fitting of the impression post on the platform of the abutment in order to have it really with passive fitting with the abutment. Once you install one piece of the abutment, another piece of the abutment, you can bond together with your acrylic resin, okay? So I have all the index in place here. What is this suture here? Actually, I was completely excited about this case. So I took a slice in the molar to make a puncture in a molar. You can ask if it's necessary to do that. Sometimes not, but when you get excited about the case, you do this kind of stuff. And I took this connective tissue in hand. Oh, what am I going to do with this connective tissue? You know, it's so difficult to get. So I did another graft tuning on the central incisors to increase the keratinization. That did not work pretty well, but I do that. It was not so, the patient was with anesthesia. I have with the connective tissue in hand, took me 10 minutes to do that. Okay, index in position, gingival margin changing. What I need to do? Send the patients home with this index to let the soft tissue to get mature? No, I need to give back the temporary. And the temporary does not have changing anything on the anatomy. I need to change that. So this is my temporary. What I need to do? Modify the shape of the temporary. Remember our cast? So let's fix the temporary on the cast. Everything I need to do is fill the gap. So we use, in this case, acrylic, and we pour acrylic on the gap, dot by dot, filling the space to have a realigned temporary. So I'm going to unscrew, make the polishment of the acrylic, and now I have a completely new alignment of the cervical margin of my temporary. So I can unscrew the gingival impression index and move back the temporary. So I use the impression index to modify the tissue position, but I need to remove the index and move back the temporary in position to wait the soft tissue to get mature. How long you need to wait? According to the modification that you are promoting, you need to wait more or less. Let's just take an example, the central incisors. I just move the zenith position. Wait 2 weeks, you can do the impression. These lateral incisors that we scrape a little bit the bone, completely move, buccal flap, the palatal flap, I wait 2 months. So you need to see different the need of the tissue. That's not a rigid and steady rule for us. So here, I think almost 2 months after that, so you see a better alignment. Now I can do the final impression. And as the tissue do not changing from the temporary shape, I know that the temporary and the index has exactly the same shape. I do not need to fabricate another index. We have stored that index and it's going to make the final impression using the same index. If I have a small difference, I can realign in the patient's mouth the index. So the index is in position. Look at the similarity of the shape of the gingiva and the index. This is amazing. And here is a picture, just 8 minutes without any support from the temporary, any support from the index. What happened here? Look at the difference on the shape of the soft tissue. So that is why we cannot try to build up an index straight in the patient's mouth, because you don't have time enough to do that. You can customize an impression post for 1 tooth. For 2, maybe the time is not enough. For a full arch is impossible. So we prefer to have that outside the mouth of the patient. And on case like this one, if you try to make an impression of silicone, you're going to promote more distortion of the shape that you already have distorted by the time. So we need to take impression using the index and the hard material to do that, okay? So the index can be used to take bite registration. That is a nice thing about the index. So we control exactly the relationship that I had on the temporary and the relationship that I'm going to registrate with the index. Of course, we changed the long screw for short one. So have half of the temporary remove make the bite registration, and move the another half away to have the full arch registration. And look at that. And now I can use a closed tray technique. Okay, how can we do that? Make an impression of silicone and remove the silicone away. Unscrew the index, screw the analogs on the index, and you're going to move this index inside the silicone. Okay, so this is our impression. All the important information are on the index. So the silicone, if you have some small difference of the fitting, that is not going to be important, not going to be meaningful, okay? So the silicone is basically a way to hold and to build up the rest of the cast, but there's no even a small important information on the silicone, okay? And for the restorative guy here, this is the most important slide of the presentation. Why is that? Okay, I have a very well-shaped temporary. So my temporary is my prototype. Everything I want to build up is pretty similar to my temporary. When you make an impression and start to do or to send that to the technician is to build up the whole art from the zero. But you already have a lot of good information. Why not to use this information? And what is this information? The temporary. With the same byte registration that you took from the index with the temporary. So in the first part of the slide, I have on the articulator, the lower arch with my working cast. We remove the upper part and we move the temporary impression in position or temporary cast in position. What are you going to do? What the technician is going to do is going to take some silicone guide around the cast of the temporary. And after this silicone guide is ready, he's going to remove the cast of the temporary and move back my working cast. So the wax up or the infrastructure is going to be built up with the guide of silicone showing for the technician exactly the length, the width, the position, the shape of the temporary that you have in the patient's mouth. It's going to be much more easier for your technician to build up the wax up, okay? So from the wax up, we train the wax up, we move to the final crown so we can really screw that in position. So this is our final bridge for the patient. This was the picture I took just after delivery. I asked for the patient, please could you smile? The patient was quite shy. Do not show the gingival margin. I showed that for my best friend dentist, and that is my associated. Look at the nice treatment, oh, outstanding treatment, but why so much work with the smile line of the patient is low? No, come on, man. I call for the patients back, and this is almost 2 years. You see the high smile line of the patient, so every small difference that you can manage here is going to be visible on the aesthetic zone. And it's a lot of work, but I think some patients deserve. It's a lot of work, but as we bring some nice tool to manage that from the planning, from the way we take the impression, from the way we take or we make the modification of the soft tissue, I can tell you that the stress in this kind of appointment is very low because it's completely technical procedures that you need to do, okay? And I think this case summarizes a lot of everything we brought as information here. This is the final case that I was to bring today. So we are open to discussion here. And I'm going to just unshare the screen so we can talk about what we present. Good.
Ooh, oh my God. That's like OMG. Amazing, amazing skills. And I believe that this is something I'm so happy for one of my decision to bring in the prosthodontist along with in the moderators along with the periodontist, because it is a combination. Alone a periodontist cannot work alone. You have to have a prosto mind set also, and I'm so happy. Uh, Before I ask something, I would like Dr. Ashvini to come up with some queries if she has, and then Dr. Rita, and then on the prosthodontic part, Dr. Radhika. So please, and then I have some questions. I will
My
come
God.
up later.
This is like opening a Pandora's box. I have so much to say about what you've shared. Amazing, absolutely amazing. Of course, the work and the result, we don't need to talk about it with you in question because it's always amazing. I mean, we've seen it all over. But what I really appreciate about what you've done in this case is one, the way you have explained that whole split thickness
Thickness.
decision. It is so beautifully explained because when we talk about split thickness, people think they can just go in and take an incision and elevate the connective tissue wherever, anywhere between the keratinized mucosa and the keratin layer and the periosteum. But the way you've actually explained it with the muscle layer, when you go into the alveolar mucosa, it's absolutely amazing to understand. And the logic, you've not just said do this, you explained why, which was simply superb. And of course the case was a lot of effort, like you said, but the end result is always something that you look up to like this, and then it's superb. I had a few questions. There were some fistulae that you had right in the beginning when you started the case. So and you did a lot of immediate extractions, placements, also implant removals in the 1-3 region, and placed in a new implant. So was there any bone dehiscence or fenestration on the buccal aspect of those implants or teeth that you extracted? And if yes, then did you do a GBR and simultaneously do a connective tissue graft, or would you stage it typically? May not be in this case, but otherwise also.
Okay, it's not a simple question.
I
No,
know, I'm sorry,
yeah,
but
that's
there's just
good.
so much
No,
going
no,
on in my mind after that
but
case
this is
that
good. Yeah. No, the reasoning is very clever. What you ask, it's something that someone that is scheming the game. It's exactly concerned the small details that make difference on the case that we need to do. Okay, on the case that I present, in one of the canine that we took the old implant, there is a fenestration. Okay, so I took a collagen membrane, carefully raised the flap from the outside the socket, and managed to arrange the collagen membrane with the biomaterial on that. And on the top of everything, carefully perform the connective tissue graft. But one thing that helped me a lot is the size of the fenestration. If the fenestration is close with the borders of the bone to each other, you can manage a lot of procedures on that. Even bring together biomaterial, guide bone regeneration with the soft tissue on the top. The problem is sometimes when you try to prepare and to bring the connective tissue, you messed up with the arrangement of the biomaterial and the collagen membrane. That is the main struggle. Okay, but you made a very nice question here that is when we need to combine bone regeneration with connective tissue graft. And I see that with a very, very careful relationship between, when I start to explain that if I bring a connective tissue that is thicker, I need to think in the blood supply, okay? So, and if I'm bone grafting some case, and on the top of my bone graft, I'm going to bring my connective tissue graft, I'm laying down my connective tissue in the surface that do not going to promote any nourishment. And so I'm trapped in not collect a good result. And in some case like this one, I prefer to stage, do bone regeneration, and after that doing my soft tissue regeneration. After the periosteum is back, that I can split and lay down my connective tissue on the top of that. If I have from my patients 10 tuberosity, you can do graft all the time, lose the graft and do it again. But sometimes I have just one good tuberosity. In that case, there was one good tuberosity, another one, there is a second molar. So it's a small tuberosity. If I use the graft from the large tuberosity in a not good situation, the result not going to be good, and I need a second shot. And I don't have all the volume that I need on the tuberosity anymore. You can harvest 2 times the tuberosity, but the second time the volume is not the same. I still have something. So we need to strategically think which time is better to approach this kind of situation. And you're completely right. Sometimes it's better to stage, to have the proper environment to bring the soft tissue graft.
Yeah, I so completely agree with you on this one because, you know, a lot of people think that you can do a lot of Herculean tasks. You can go and do GBR and put a connect, and nothing works because they need to understand how this needs to be staged depending on the need. Also, one more thing that intrigues me a lot about that case is you did not raise flaps. Like even if you had a fenestration, you have gone in and minimally invasively approach that fenestration for the GBR as well as to place your CTG in, you know. So of course, CTG would be flapless, but with the GBR, many of us would many a times probably raise a flap to actually get access to these kind of cases which are infected and, you know, have a lot to probably address at that point of time during the surgery. So that was one. And you said that you prefer you know, acrylic over composite for your provisionals. I mean, yeah. Anybody? I mean, there's a lot of us who do prefer something like a composite to especially reline the provisionals. Otherwise, we do use materials like a protem for making our provisionals, but to reline and that cervical area. So any particular reason that you see choosing this over composites?
No, it's when you are getting old, you get stuck to old habits, you know? So when I start to work with temporaries made of acrylic. And of course, the best material to realign acrylic is acrylic. So yeah. I get used, and I have a lot of, how can I say, I like to work with acrylic. So for me, it's not so complicated to do the realignment with the acrylic. And every time I need to bond composite over the acrylic, you know that is not the perfect bonded surface to one and another. So I prefer to use really acrylic when I can. And it's easier to use the composite, so small surface. And I can, like I said, if you need to make a realignment to stay 1 month, that's okay. 2 months, that's okay. But there is some case that I let 4 or 5 months, the temporary just there. So just to see if I have some modification of the soft tissue. So I prefer not to use a composite with the acrylic in so long term in this way. So I prefer to use whole acrylic. So, but it's not specific. No, I use both.
All right, great, thanks. Dr. Sandeep, can I ask 1 or 2 more, or am I taking too much of time?
No, you can ask because we are here to discuss.
Okay, what is your go-to site for a CTG? Is it the tuberosity?
Oh, wow.
I'm sorry, you know, let me just...
yeah, okay. According to the proposition what I'm working with, okay, like root covering usually is a depitalized 3-gingival graft. Okay, it's easier to trim, easier to cut, faster. You design the shape you want, and easy busy. What the tuberosity give me is thickness. and a good post-op for the patient. Okay, I still have a third option, that is trapdoor and go deep on this area. So the fat contained is larger, and you have maybe a connective tissue that is going to reabsorb a little bit of the total volume. But I still use this connective tissue deep from the palate, from some case very aesthetic demanding, and I want that the result of the treatment don't have any changing from the surrounding areas. I want that the result is being more similar to the flap than the connective tissue graft. And we are learning, but I have in some cases, when I took the deeptilized connective tissue graft and I use that in the aesthetic zone, sometimes I have some small places that the surface is more related in the aesthetic outcome with the graft than with the flap. And that happens in my hand more with the deeptilized connective tissue graft than the one I took deep on the palate. So we need to be very careful on that, especially in thin phenotypes.
Yeah.
When the phenotype of the flap is very thin, I'm very careful on that. Even using sometimes full thickness flap, when I have the result is the grafting showing up. And so deep on the palate, I have better result with that. So I use the three sources. I do not use just one. So also understanding the difference.
And do you always prefer free grafts, or what's your take on VIP CTs, especially in the anterior zone, the vascularized interpositional connective tissue grafts?
So that can complement one of your questions when you told about not mixing or avoid mixing bone grafting with tissue graft. And there is some case that I extract the implant, I have a day sense, I need to treat, I need to use bone graft, and it's a single tooth. I bring it pediculated, because when you bring it pediculated, you bring with the periosteum.
That's supply.
Blood
Vascular
supply, so you can support and you can lay down over bone graft, and even though not having a good flap or some exposition of this connective tissue, it's going to survive. So we use that also. So we use everything.
I know. And at your hands, I think it all works with magic, so it's really great. Okay, last question. What is, I'm sorry, but there's just so much that
Please.
What's your, I hope you're okay with answering my questions, Dr. Kern.
Okay.
So how would you handle deficient keratinized mucosa around the peri-implant tissues? Because that's one thing that I think is very often not really considered, and it is the most important. If you ask me, at the end of the day, a deficient keratinized mucosa is what will lead to most perimucositis and implantitis. So a lot of people tend to absolutely overlook it. And what is your kind of, let's not talk about full mouths. I mean, it becomes a more difficult proposition, but one or two implants, single implants, how do you tackle peri-implant deficient keratinized mucosa?
Okay, the keratinized tissue is fundamental. We need to be concerned, and from the beginning, before place the implants, to create the right environment for our implant. But if we need to fix deficiency in the keratinized zone on over implant, one of the good option is still the free gingival graft. And if you're thinking just in create keratinization, of course, the free gingival graft is the first option for us to apply. You are going to play in a safe outcome. You can expect that the outcome is going to be very, very related to the surgery, comparing to the connective tissue graft, because sometimes the connective tissue graft, you gain volume, but the keratinization create as result maybe is not so good as you could use a free gingival graft. There is a very good point here, because the way we treat the tissues, we split mucosa from the muscles from the ground. and we lay down the connective tissue. It's different when you do splitting that you're not caring about which layer you are splitting. You let some muscles on the mucosa, and you can have different results, because if I use a connective tissue with a completely clean layering of the flap, sometimes the result create better keratinization than when you took a connective tissue under a flap that has a lot of muscles and so on. So the result is not good. So when we understand and we will learn how to organize the flap to receive, you can have both results for both techniques, but free gingival graft is as it's something that must be considered in first place, especially in not aesthetic zone. So, but even though
any experience with the 3D collagen matrices that you get, like a Mucograph?
no, I do not
Have you
have
used
so
them?
many experience in this kind of materials. So I'm not the right guy to bring that in this subject. So my opinion is just for a few cases, and I still love.
Yeah, likewise.
You know, the way we treat the donor site nowadays, the patients do not complain about that anymore. So the patients, some years ago, the patients came in and how was the surgery? Oh my, the donor site. First thing.
Yeah.
Nowadays, the patients came, how was the surgery? Ah, it was okay. Ta-da, ta-da. I took care this way, that way, and your roof of the mouth. Ah, that's okay also. So you feel more confident to continue use the autologous sources of the graft. So I still like that. Okay.
Great. I could go on, like I said, but I need to pass the baton on. And before I, go on to Dr. Rita with her questioning, amazing. It was an absolute pleasure to be there through this presentation and hear you speak. And the way you teach, you're an amazing teacher. I must tell you that, because it's an art to teach so well. And what I really appreciate is the importance of the whole interdisciplinary approach that you have, stressed, because it's not just perio, it's not just prostho. It needs to be to get that end result. You need to have it all together. It is a mixed bag, and you need to handle each parcel in that bag really well to get where you have at the end. Thank you so much. It's been a pleasure. Thank you, Dr. Sandeep. Dr. Rita, over to you.
Yeah, yeah.
Thank you. So you did a complete justice to the title. The tissue is an issue. I mean, what an explanation. I mean, I can go on and on with it, but to cut it short, what I felt when you were showing your last case, I could imagine an old house being renovated with the plumber and the electrician and, that kind of work. I mean, a lot of work you've done in that case. But I just want to ask you about the grafts again, the connective tissue grafts. What instructions, post-op or post-surgical instructions would you give to your patients in the recipient side?
Okay, good. That is good information. But what I tell the patients, do not touch. Do not do anything. Do not try to clean that. Even with cotton balls, do not use that, because there is a few cases that some patients even using very soft cotton balls with chlorhexidine, they still brushes over that. What I do the surgery and I tell the patients, you have chlorhexidine twice a day, but not mouth rinses. Just bring in place 1 minute and spit. That's it. In 4-5 days, you're going to be back here and I'm going to clean it for you. Okay, I'm going to see how it's going on, if I have a problem or not, and I'm going to clean the area. That's it. And he returned between 7 to 10 days, and I'm going to clean it again. And in 7 to 10 days, most of the case, I remove most of the sutures. I just let in the sutures from the ground, that is the resorbable ones, and that's it. But from the border of the flap, the superficial layers, sutures, I remove everything. And the patient still do not touch the area. So after 2 weeks to 3 weeks, I receive the patient again, and from that point, I start to instruct the patient how to clean. All very soft brushes, or they start with cotton balls gently, and I start to move that, because after 2 weeks, I already had a large degrees of the vascularization of this area again, so the patients can have some small cleaning on the area. So between the second and 2 weeks, and that according to the size of the graft also. So a smaller graft is not so concerned. Larger one, I'm more concerned of the trauma, the mechanical movement of this area. And from the last year from now, in some cases we are applying also not chlorhexidine, we are applying the ozone gel, that is the Blue M, yes, with similar results. I think it's biologically speaking, it's a good option to have also.
So do you also give it to your patients?
The Blue M?
Yes.
Yes, yeah. He apply over the area.
So the gel and the mouthwash both.
Yeah.
Okay.
You did mention something about suturing, never suture. I mean, I did not get that part. Could you just briefly touch upon that? When you graft the connective tissue, you said you never suture somewhere. I did not get that part. Sorry.
Okay. No, usually the first layer of the suture, I'm just concerned of bringing the connective tissue against the recipient area. Mm-hmm. So, and the flap, I never suture the flap in this stage. The flap stays loose there, and I still have completely stable the connective tissue. I do not use any sutures bringing the flap over or connecting everything. So the flap is the last stage that I brought from sutures. So another approach of sutures just to bring the flap over the connective tissue. Okay. Yeah.
One small question. Have you ever had an experience where you are in a negative position, in the sense you're worse than where you started?
I'm sorry, can you repeat?
Normally, when we do connective tissue grafts, it's not very, very predictable. Sometimes you are in a minus position, you land in a position where you are worse than the starting point. Have you had that kind of an experience?
Yes, of course. We had it. But, I think connective tissue, I think it's more predictable than bone grafting. Still, I think it's okay. And of course, the first stage, how to work with connective tissue, is going to give you a lot of failures until you identify how to work and so on. But yes, we had some cases that, but that is not because of the skills. That is because I did not understand sometimes the situation. And I have some example in the past that I tried to fix some deficiencies around the implants. And I tried to fix many cases. This work does not work. This work does not. Why this work and why this not work? And that was in the beginning, was not the surgery, because I applied a surgery that was not suited for that case. Oh, the case was already compromised at some point. Nowadays, I know exactly which case I'm going to graft, in which case I need to extract the implant and going to do another option. So we are more selective, and we learn that, because this information is rare. You do not find this information available. And for many years, we work without this information. So let's shoot all around, which you can collect, not repeat. And that's, I think, why the pictures help me so much. When I revisit the case from 8, 9, 10 years ago, and wow, look at this work, this not work, and I get something here, something there. So we are in the beginning, as Sandeep, okay, people in India do not are so concerned about soft tissue. In Brazil also, it's not everybody that is doing that, but every time, every week is more people interested in the subject and try to learn. I do perio. When I did perio in Brazil, nobody was doing perio. They are doing implants, book maxillofacial. And why are you going to do perio, man? Just extract and do the implant, something like that. And nowadays, everybody is looking for soft tissue surgery and try to learn a little bit more of perio. So, and you're going to have a lot of development in this field. The information that we have in bone grafting is 10 times higher than in the soft tissue graft, at least in this kind of volume that we need and so on. So we just in the first stages, I think.
But I think that that's the most important thing when we are dealing with the implants. If you do not know about the perioplastic surgeries, I believe I always tell people that stop doing implants. Don't do that.
And
Yeah.
Ricardo has always encouraged people to do soft tissue grafts through his Facebook post and through the courses. I had the opportunity to attend his course, and it's amazing. And I really like the way you think, before you design the flap or the incision, taking into consideration the histology and the anatomy. I think that is what we need to learn. Thank you so much. And I pass it over to Dr.
Dr. Radhika. Dr. Radhika, I think you must be really full of questions, and you must have appreciated the new way of, because that's the way I saw the first time, that how to take impression, closed tray impression, not
Yeah.
going into the open tray, and creating an index. So please.
So, Dr. Kern, thank you so much. I'm not going to bore you with the perio questions. I think my colleagues have done enough of that. We'll go straight to prosthetics now. I love the concept of closed tray impression making because, like you said, an open tray impression making can really get very, very tedious and messy by the end of it. But whenever you're doing, you're not really opening up the gingiva to do your implants. So how much of the digital platform are you using? Are you making surgical trays to do your surgical templates to place the implant? Number one. Are you using the surgical guide to also make your temporization before you go in for the surgery? How much of the digital platform are you using in your surgeries?
Okay, good question. Very few.
Because
Very
as
few.
of now, and so you're not even doing any digital scans. You're still using the analogs and.
No, yeah, exactly. Okay, that's I don't have scans in my clinic. Okay, so we still analog way. I think both work greatly if you know what you need from which of system. So you can do bad stuff in analog way and the same in digital way. But the guide implant is something that is just increase a lot. What I do when I planning a case, I spend a lot of time looking to the CBCT scan of the patient and the walks up and so on. I send this information from my technician and I know exactly where the implant is going to be fixed, the situation. So I extract the socket and I use my temporary as a kind of a guide, because the temporary helped me to really move maybe that implant 1 millimeter more distally or more medially. So the first reel already go inside in the proper site. Yeah. So it's not guided implant. So, but I use the temporary. And after I use the temporary to choose the abutment, how to angulate the abutment and move and so on. So in case like that, the one that you saw, the temporary helped me a lot to fix the implant in place. And I do that free-handed. But I still need to move more to guide. It's something that is in our futures. It's inevitable.
So it's just that when you start using the guided surgery, the steps that you showed actually get reduced to just 2 steps. Because you can start planning your temporary is ready much before you start your surgery. And when you place the temporary in the mouth, you are kind of, like you had to have 2 surgeries done. Two temporaries made. One was during your surgery and another temporary had to be redone when your soft tissue was done. And you also had to redo your pontic area, the gingiva and the pontic area, and redo the entire temporization. So in that case, I think there are a lot of places where we can just, forego the second step. We can develop the pontic site on the first go.
No.
No, I disagree too. Yeah, I agree with Dr. Kern.
Okay, let's see how you and us can make it happen. Let's see why you disagree and then why I'll tell you why I want to put it forward that way.
Yeah, no, but it's a very good question, because there is one basic point for us to discuss around, okay? When I graft the connective tissue, I need to open space. So I completely distorted my emergence profile for the crown. No. So after the healing, I saw for my temporary, and the temporary is completely unbalanced. So there is any point up, there's any point down, but I just need to do that in the second stage, after I had my soft tissue healed. We have been doing some case with the digital workflow. And I'm going to tell you one thing. It's not the technique, it's how the way we learn how to work. When I have a full arch with extraction, with temporization, I'm very concerned about one thing about my temporary. You have the right design, the right position, right color, right middle line, right incisional edge, and so on. But there is something that is very difficult for the technician to understand. I need that my temporary goes inside the socket at least 1 millimeter, respecting exactly the socket contour. So usually when the technician is working on the cast, they do not respect the socket entrance, because this 1 millimeter is going to help me to seal the socket entrance, to protect the blood clot, the biomaterial, to hold and to maintain mechanically the papilla in position. Because if I have a gap, mechanically the papilla is going to just, if I have overcompressed, I can have a receding of the papilla. So they need to learn, the technician need to learn exactly the line of the socket entrance and preserve that, respect that. And that can be done digitally or in analog way. Took me a lot of time to have this relationship with my technician that is still nowadays is analog guy. And when we move for the digital, we in another technicians, they quite not understand that. And we received the temporary and we lost a long time, fix that, contouring and so on. Because on the realignment that we have 6 implant and the pontics to realign, it's a lot of work. But imagine one thing. What is the perfect emergence profile that we are discussing? Umbrella concept, concave emergence profile, that's okay. Until which level? The first millimeter of the socket entrance. So from that 1 millimeter deep, you're going to shape a concave emergence profile. If I have this 1 millimeter ready, analogical way or digitally, how is the shape of my realignment? concave.
Right.
So I do not need to concern to give any anatomy. I just need to promote concave surface. That is much more easier for me if I receive this information ready from the lab. And until nowadays, my technician that completely does understand me work on the cast. It's easy. Digitally, when we have some case done digitally, okay, I lost a lot of time. And you have surgery, you have implants, and after that you need to have a lot of time working in the temporary. The temporary gives more work than the surgery. And if you have that not well designed, it's going to have a lot of problem. Good.
So I guess it's the ease that you have developed with your lab technician that makes you think like that. I think I should talk to you again in a year's time when you get comfortable working the digital way and talking to your lab technician that way. Yes, but thank you so much. This is a very good way of explaining to the rest of us who don't have the digital concept yet in their practices as to how to manage the cases and manage them really beautifully. Thank you. Thank you so much.
Thank you. Thank you, Dr. Radhika. It was wonderful. And I believe Dr. Ashvini, Dr. Rita, and Dr. Radhika has asked many of the questions which I had in my mind. So I'll not repeat it. But one thing I would like to say that what Dr. Ricardo has told us, uh, it is not only we are supposed to uh, go into his workshop and learn things, we should bring in our technician also. True. Because the technician, because it has something to do into work in sync with technician. So I believe when I will get in touch with him and I would like to learn from him, I will bring in my technician also along with me because that is very important. Another question which I had in my mind, when you do the partial thickness flap, uh, uh, when you are trying to release the muscles and your flap, dissecting it, do you do blunt dissection or you have any special instrument to lift it or to separate it from the muscles?
Okay, I prefer to use blades. Okay, if I have access, I'm going to use the 15C blade. If I do not have the proper access, sometimes I use angulated blade, ophthalmic blade, or a blade that I can bendle and work on that. Because I think it's more clean and you treat better the flap using blades than blunt instruments. But blunt instruments also work in some kind of degrees. You can split that using a blunt instrument, okay? I use blunt instruments to check if I had releasing and detached all the muscles from the mucosa. So I just going up and down with a blunt instrument, and sometimes I have some fibers in the way. I fill that in with the blunt instrument, I detach that. So you can use also. We use both.
Thank you. I mean, the message goes out to the people over there who are listening to you, and us that if they would like to try as you have explained, they should attend your workshop first and then attempt it, because with the blade, if they try to do it, they may cut the muscles, and a disaster can happen. The third question which I had in my mind, it has been already answered, but it was like you love taking out FGG rather than CTG, because I had that thing in my mind. The shrinkage of CTG is always there, because when you take out some fat cells and globules are there and it shrinks. So taking out the FGG and then deepithelizing it and using it as a CTG is always better. And beveling, which was very well explained, because it becomes easier to fit in, and that thing is very good, and you can have a desired thickness of your CTG, because when you do a CTG taking out, you need a lot of expertise. Yeah. And your experience with PET, which I believe you do little bit, or because many of the people who are talking about PET technique, partial extraction therapy, they say that we do not have to go for any soft tissue modifications because whatever is there, it is being retained. So, yeah.
No. Okay. First time I saw the technique,
Yeah.
socket shield, I was doing immediate implant with immediate temporization for many years. I started doing my first immediate implant maybe 2004, 2005. So was long time that I was doing the procedure, and you feel confident in that procedure. So when I saw people doing socket shield, first, or the first thing, that is crazy. That's not work. That's going to be a lot of problems. But of course, I was ignorant about the technique and what was behind. And I think that it's a very good technique, a very good tool to learn and to execute and to have in hands. Because there are really some cases that the socket shield is the first indication. I have been done cases of socket shield now for 4 or 5 years. The first case I have been doing. But first thing is not easy. Socket shield for you to do very nice is not so easy. It's as difficult as to take a connective tissue, tunneling, and so on. So the results that I see on the literature of nothing being, how can I say, in agreement, because you have bad results, a lot of papers talking that there is a lot of complication, and you have nice results, is because the technique is still need to be more comprehended and well executed, because it's not simple. It's demand a lot of attention, skills, and so on to perform that in the right way. But once you did that in the right way, it's an amazing tool, an amazing technique to use.
Thank you so much for the answers. And there was one more thing because I think most of I do you have any more case or we will finish up now? Yeah. Okay. 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 So as Dr. Ashvini talked about alternatives for CTG and FGG, you don't like it, but I believe in your country there's a lot of fibroguide and mucografts. It is being here in India also, and uh, as you said, it's golden thumb rule to use more of the connective tissue. So I will not talk about that. And the last thing is like PTCTG, what Dr. Ashwini had asked about, the VIP flap or the pedicle tunnel connective tissue graft. Uh, Dr. Snejana Paul has come up with a modified Ivan technique, which is like she splits it open, do not do tunneling, and then reflects the connective tissue. But definitely it is only for one single anterior aesthetic zone. So you have already given explanation to that. Thank you so much for being here with us for such a wonderful presentation. It was the most amazing one. And I would love to, I would like to thank Dr. Deepak Rai also for bringing you down to India for the first time. It was really nice of him. And to our viewers, I can say that if we get a chance, because the traveling is going to be very difficult in coming years, coming months. So till everything is not open, if people demand, we can have a virtual course onto, because this is the most um, amazing gift COVID has given us. COVID-19 has given us the collateral damage. It is very much, but the collateral benefit of COVID is the virtual platform has come up as the one of the strongest medium for education. And today, what you did was amazing. So thank you so much. And if people agree and if they demand, I believe you will be ready to come up onto the virtual platform to have a wonderful class where you can show in detail everything.
For sure. Yes. Just so grateful to have all you guys here. It was super nice discussion. The high level questions. It was really a pleasure to talk to you. Just ending this webinar here and going back very happy to have this good time with you. So thank a lot, everybody. And
Thank you, Dr. Kern.
Thank you so much. We
Thank
give
you.
you
Thank you so much, Dr. Ricardo.
the universal greeting which has become namaste.
Namaste.
Thank you, and,
And-
you have a great day, and we need to say good
Yeah.
night to each other.
Yeah. So have a great Sunday, and thank you so much. And again, before we go, I would like to tell people that he has a wonderful academy where he does educational activities. So anybody can just write down his name and come to his web page available there. And any information they want, they can get in touch with Dr. Ricardo, or they can get in touch with me also. Thank you so much for being with us, to all my viewers, and to all those great speakers who had come down to on our ultimate talk show. I am grateful again to them. And this was supposed to be the last lockdown day for India, 31st. So I thought that this is going to be the last webinar, but we have 2-3 more, which will be with Dr. Tali Shakrashi from Israel and Professor Anton Skulyan together, and one recorded video from Dr. Otto Zur is going to be there, and one small lecture from Dr. Rajiv Verma, sir. So thank you so much for being with us, and we will see you again. Bye-bye. Good night.
Thank you.
Bye-bye.
Namaste.
Bye. Thank you.
Yeah.
Thank you.